Good afternoon, everyone. I'd like to thank Dr. Jyotidev and his team for this wonderful meeting. This is an oration, and I'd like to invite Professor S V Madhu to the dais. Dr. Madhu is the professor and head of the Department of Diabetes, Endocrine and Metabolism, GTB Hospital, Delhi. The talk is on targeting and protecting the liver in patients with type 2 diabetes. As you are aware, with more and more therapies into practice, liver becomes a very important organ for target in terms of certain treatment modalities. And when it comes to adverse events on the liver, we have a host of adverse events starting from fatty liver to non-alcoholic fatty liver disease to cirrhosis. So in the next 20 minutes, Dr. Madhu will talk to us on all these aspects of diabetes. I'll invite him to start his talk.
Thank you, Chairperson. And I also wish to thank Dr. Jyotidev and the members of the organizing committee for inviting me to give this oration here. It's always a pleasure to be in Kerala, in Trivandrum to give this talk. I must say that I do not directly have any original work on this particular area, but this was on request of Dr. Jyotidev, which I tried to prepare this talk and try to give it 3 or 4 aspects of its importance, especially trying to understand the various aspects of liver involvement, which has already been mentioned by the chairperson about fatty liver and all the NAFLD story and how it is linked to diabetes, a little bit of understanding how it happens, and then go on to see if it needs to be targeted and what for, and do we have anything to do about it. This is the institution where I work, and that's the Center of Diabetes at our institute. The brief outline over the next 20 minutes would be after an introduction of the topic, and we'll talk about the risk factors, the pathogenesis, and what are the concepts of ectopic fat, hepatic fat. Actually, fatty liver or the liver is basically, the disease is basically fat in the liver, and the consequences of the fat in the liver, insulin resistance and diabetes. Does NAFLD contribute to increased risk of diabetes and cardiovascular disease? We'll ask that question and look at evidence. Why is it important in Indians? Is it more important than the rest of the world or other races? And what are the treatment approaches available? Are they effective? And can we do anything to treat? We've heard, or we know probably, that it's a commonest clinically important type of chronic liver disease. The non-alcoholic fatty liver disease is very common, and especially with the increasing epidemic of obesity and diabetes in our country, we are seeing cases of fatty liver on the spectrum of non-alcoholic fatty liver disease quite often. The entire spectrum of liver disease without significant alcohol consumption is probably the most important clue. It's progressive, and as already been mentioned, it can lead to end-stage liver disease. Liver failure is an important complication, some of them, and even hepatic carcinoma can evolve. But what is important from our perspective and what dictates the outcome in this condition is actually the cardiovascular risk potential. It's been well established that non-alcoholic fatty liver disease is a hepatic manifestation of metabolic syndrome. Many people have several things or several aspects of metabolic syndrome that we know. This is termed the hepatic manifestation. In India, the prevalence varies from 9 to 32%, which is a huge number. And most of the high numbers come from metropolitan cities, as we can well imagine, because of increasing obesity and diabetes rates. The mortality, as I've just alluded to, is strongly associated with the cardiovascular disease component. So it's basically the risk for diabetes or cardiometabolic risk, shall we say, which determines the seriousness of this condition, why probably this topic was chosen. Should we target the liver when we are managing either diabetes or the metabolic syndrome or all that has got to do with this syndrome? The spectrum, as we can see in this slide, is very simple. When there is just fat, you have steatosis. When you have inflammation along with the fat, you have NASH, steatohepatitis, and later on you have cirrhosis, and of course sometimes hepatocellular carcinoma. This is the entire spectrum. As long as it is just steatosis, it's probably less harmful. It does have some risk, but once the stage of NASH is supervenes, then probably the risk potential in terms of cardiovascular disease, diabetes risk, and inflammation, and a whole lot of complications increases substantially, and that's where we are bothered about. And this can progress to fibrosis and cirrhosis and so on. What are the risk factors of hepatosteatosis? Excess body fat is one of the most important risk factors, and in this context, we are all aware that adiposity, whether it is subcutaneous, intra-abdominal, is more important. But sometimes even lipodystrophies can lead to fatty liver. How, we'll not get into it today, but there are certain genetic factors which make a lipodystrophy on the one side and hepatosteatosis, NAFLD on the other. Age and gender, more common in men below 50, but in women generally seen after 60, but no age is any bar. Asian Indians are particularly prone to this condition. Fructose, as many of us probably know, is one of the important dietary components which can specifically cause hepatic fat deposition. Of course, carbohydrates, saturated fat, trans fatty acids, and to some extent vitamin D deficiency also probably is associated with hepatic steatosis. Physical inactivity we know, and a whole lot of genes have also been identified, which probably accounts for about 39% of cases which are actually heritable. Why genes is important is not every patient who takes all these excess fat or obese will have similar degrees of NAFLD. Probably the extent to which the liver is involved, the extent to which the fibrosis can occur, or the extent to which this can progress, probably to some extent is also determined by the genetic milieu in that particular individual. This is the key slide to understand. Although we think of this as a different condition, and many times we talk of NAFLD as an independent entity, what we need to understand or bear in mind is it's just a part of the entire energy balance sequence. It's just a fat deposition like any other organ during the course of a metabolic syndrome, diabetes, and so on. For example, as you can see very clearly in this slide, whether you have increased caloric intake or decreased energy expenditure, you have a positive energy balance. We all know that. Once you have positive energy balance, it gets stored as fat in the adipose tissue. And now whether the fat is inflamed or because of other reasons which do not permit trapping of the fat into the adipose tissue for one reason or the other, this fat, instead of getting deposited in the adipose tissue, either because it's been saturated fully or because some other factor is operating which doesn't allow the trapping of triglycerides into the fat, gets into the circulation and starts getting deposited in other organs. For example, the liver, the pancreas, the muscle, or the heart. And in these three sites, it causes insulin resistance. Insulin resistance, all the three. These two primarily, and here even beta cell dysfunction. Heart, of course, has some other effects, and we are focusing only on one of those organs which are damaged or which has this ectopic fat deposition. This sets off a chain of events which results in insulin resistance. We'll see a little more on the subsequent slides. But what we need to understand is that fatty liver or liver is just a part of the sequence. It's not a separate disease. And what is important in diabetes or those who are predisposed to diabetes is that you have a lot of fat into the circulation, and even though you have, and what determines whether what you eat comes into this circulation, doesn't get stored, also depends upon the plasticity of the adipose tissue, which is genetically determined. How much that fat or subcutaneous reservoirs are available, which can trap the energy in forms of triglycerides, that is a major determinant. And in this aspect, we've done some work on postprandial triglyceridemia, and the more the postprandial triglyceridemia, the more would be available fat to be deposited in the liver. So this is what actually happens in sequence, and you have a lot of TGs getting deposited in the fat, and the source can be either the diet or the adipose tissue itself, or being produced within the liver itself. Normally, what we need to understand a bit is, normally the triglyceride, this is a normal situation with very little fat in the liver. In this case, the triglycerides are not accumulating. Most of the fats are operating normally. The insulin is working, as you will see. insulin is working, and it cuts off VLDL1 production, and most of the VLDL in the body which is circulating is in the VLDL2 form, which is a relatively healthier form of VLDL. And when you have insulin resistance and you have high liver fat, this is what is happening. Most of the TG is accumulating, there's a lot of insulin resistance, insulin is not working properly, and you have a lot of VLDL1 production, and we'll come to that when we talk of cardiovascular risk. So that much we need to understand about the pathophysiology, and this results in insulin resistance as we were talking. And once we've understood this, we know why there is a huge cardiometabolic risk as is shown in this study. NAFLD is associated with insulin resistance, that's very clear. And it is believed that first it is the insulin resistance during steatosis, then the second hit causes the inflammation or the NASH, in which lipid peroxidation or ROS operates, and finally leptin and others probably also hit, and that is what finally pushes it to cirrhosis. This is the sequence of the two-hit theory. So if we understood the pathogenesis, now we come to the links with diabetes and cardiovascular disease. Quickly we will see what is the link between NAFLD and type 2 diabetes. For example, NAFLD is common in diabetics, more than 75% have fatty liver. By ultrasound, there's a 2.5 times increased risk of NASH in hyperglycemic individuals, and many of the patients manifest by increased SGOT, SGPT, which can predict future development of diabetes. There is a lot of risk. And this study showed that the risk of type 2 diabetes in those who were normal glucose tolerance to begin with but had evidence of NASH, you can very clearly see the increased risk of type 2 diabetes in the long run. Another study again shows in Koreans that if you have NAFLD to begin with, you have a very high incidence of insulin resistance, obesity, and if you have all these three together, you have plenty of type 2 diabetes. This is another Korean study which again shows the odds of having type 2 diabetes is much more if you have NAFLD than if you do not have. So increased risk of development of diabetes. And therefore, if this section very clearly establishes, I'm not going through the details of these studies, but very clearly the presence of NAFLD predicts diabetes in the long run. Now we talk of cardiovascular disease. We know and we are familiar with atherogenic dyslipidemia. Liver fat content is very closely linked to atherogenic dyslipidemia. That is what we need to understand. For example, as we just saw a couple of minutes ago, liver fat content drives VLDL1 production, and it is this VLDL1 production or large VLDL which is resulting into the small dense LDL, which we have heard quite often, and the decreased HDL, which we also have heard quite often, both of which are well-known cardiovascular risk markers. And therefore, whenever you have excess fat deposited in the liver, you have excess of VLDL1, and you have this atherogenic dyslipidemia developing. That means hepatic fat is the driver of atherogenic dyslipidemia in a metabolic syndrome or diabetes. And therefore, a cardiovascular risk is bound to be there. And once you have the additional features along with this VLDL1, these factors are all operating together, fatty liver, increasing atherogenesis. In addition, you have chronic inflammation and all the other things that we know, again, increased atherothrombosis. In fact, if you were to investigate, you will very clearly know that there is a very high risk of subclinical atherosclerosis through various mechanisms. And these studies very clearly show and prove actually that there is an independent risk of CVD with NAFLD, which is independent of other risk factors. Again, all-cause CVD and liver-related mortality also are increased in NASH. So presence or absence of rash is an independent risk marker for cardiovascular disease. So what do we understand from all this? Increased hepatic fat induces hepatic and whole body insulin resistance and drives atherogenic dyslipidemia. Number one. Increased risk of incident type 2 diabetes and difficulty in achieving glycemic control observed with NAFLD. Number two, again resulting in excess cardiovascular risk. NAFLD independently is associated with subclinical atherosclerosis. Number three, increased incidence, extent and severity of CVD in presence of NAFLD occurs independent of all other factors. So it's important as a target. And therefore, once you detect NAFLD, you must always look for other cardiovascular risk markers because they will all act together. Therefore, it is important that liver should be a target because of a huge increase in cardiovascular risk. Now, why do we bother as Indians? Do we have any evidence to suggest that it is particularly important in Indians? Are NAFLD, insulin resistance, and subclinical inflammation more severe in South Asians? That is the question. As you can see from one of the studies from our country, from Delhi, all the metabolic covariates in North Indians with NAFLD were shown to be higher. The yellow is the absence of NAFLD, the red is the NAFLD, and you can see almost every metabolic parameter is higher. And this is a key slide which shows that the liver triglycerides in South Asians are much more than Caucasians. See, so in general, hepatic fat is much more deposited in Indians or Asian Indians as compared to white Caucasians, which means we have more fatty liver compared to the Westerners, which means there is more insulin resistance because the adiponectin is lower, and which means there is higher subclinical inflammation than other races. Therefore, we need to bother about this condition more than the Caucasians. Also, the HSCRP is much more if you have NAFLD as compared to a situation where you don't have increased NAFLD. This is just to show that the severity of CAD is also much more if you have NAFLD than if you don't. Therefore, we need to bother as Indians. What can we do? Now, having established that liver needs to be a target because of the enhanced cardiometabolic risk, because of a lot of compelling evidence, what is it that we can do about it? What are the treatment approaches available? Do we have anything at all to really treat and alter the course? To date, there is no standardized treatment of NAFLD and no consensus on which exists which is appropriate for most patients. That is the sad part. However, there are several therapeutic guidelines, and we'll just go through very quickly what is possible and can we prevent at all. Alcohol consumption, even in NAFLD, should be restricted. Number one, it's a general advice. Hepatotoxic drugs to be avoided. Again, any liver disease you should avoid. Therefore, unless it's a mild fatty steatosis, in NAFLD, especially the NASH, you should try and avoid hepatotoxic drugs. This is the list which is available. Only to show that when the list is longer, there are very few effective measures available to treat. We'll briefly talk about glitazones and vitamin E, because these are the only two agents which have shown to have some clear-cut effect, but they have their own problems apart from lifestyle. Metformin doesn't work, and many of these drugs which we tend to use quite often in our clinical practice actually has very little potential and no direct proof. So we should not use UDCA, no use. Omega-3 fatty acids, no use. Pentoxifylline, some people recommend, maybe some antioxidant effect, but again, no established effect. There are some drugs in the development which are yet in the research fold. So we'll briefly talk only about glitazones and vitamin E, which has actually been studied in a randomized controlled trial. We'll come back to this. This is what this study was. They took patients with NASH, without diabetes mellitus, cirrhosis and so on, and did a randomized controlled trial. What did they find? Vitamin E actually caused 43% improvement versus placebo in relation to steatosis, lobular inflammation, hepatocellular ballooning, and fibrosis. So hepatic parameters or histology improved significantly. Pioglitazone also had a modest or more or less similar but slightly less improvement in histology. Vitamin E also reduced the SGOT and SGPT. Pioglitazone, in addition to all this, also improved to some extent the lobular inflammation also. However, and as we know, vitamin E was superior to placebo, especially in those without diabetes mellitus. This trial was done in NASH. In the group without diabetes mellitus, it was more effective. Pioglitazone may have a role in treating patients with biopsy-proven NASH, but again, the long-term safety is not established. So these two drugs have shown some intermediate effects. Vitamin E again has concerns. If you see this, it enhances cardiovascular mortality or independently all-cause mortality. In other studies, it's been shown vitamin D is associated with that. So while it decreases or improves the liver histology, you have to balance it with this additional risk which vitamin D also has. So one has to be very cautious. Therefore, weight loss and pioglitazone seem to be extensively beneficial, as we will just see. They have been shown not only to improve liver disease but also the cardiometabolic outcomes. So again, vitamin E improves liver histology, not cardiometabolic outcomes. Pioglitazone and lifestyle improve both to some extent. Lifestyle is the safest, which we are anyway going to advise to all metabolic syndrome, obese patients or diabetic patients. We should stick to a plan of lifestyle in patients with NAFLD. The AASLD recommendations are therefore that in some cases, this is regarding pharmacotherapy, lifestyle is the only cornerstone. Pioglitazone can be used to treat certain patients with biopsy-proven NASH who do not have diabetes mellitus, but keeping the long-term side effects in the balance. Vitamin D, 800 international units per day, can help, but it is not recommended in NASH associated with diabetics, cirrhosis, cryptogenic cirrhosis, or other patients. So that means what? At the end of it, while we've got a huge list of agents, it's lifestyle. We are back to lifestyle as the only available option, with some selected patients where we can use either pioglitazone or vitamin D with all its limitations. So how do we summarize the entire thing? Whatever we've talked in the last 18 minutes or so, let me summarize in the last 2 slides. In terms of how do we summarize the approach to NAFLD and ASH. NAFLD and ASH represents a major global public health problem, particularly important for India, as I've shown. But there is insufficient evidence to suggest that you should screen for NASH routinely. So that's number one. The diagnosis should be sought in all patients who present with risk factors for NASH, which I've listed in the beginning. There you need to seek. Don't have to screen everybody. Not all patients with risk factors will have NAFLD and vice versa. We need to understand that. Not every person with fatty liver needs aggressive therapy. So don't talk of pharmacotherapy in every patient with fatty liver disease. Diet and exercise should be instituted for all. Universal recommendations known to have definite effects on histology. Liver biopsy should be reserved for those patients who have risk factors for NASH and or other liver diseases. Otherwise, you don't need to do liver biopsy as a routine. And patients with NASH or risk factors for NASH should be first treated with diet and exercise. Only when that doesn't work, some people, when it is given a trial of 6 months to a year, it doesn't work, then you might think of vitamin E or pioglitazone in a select few patients. And conclude, the treatment of NAFLD is based on the correction of causing factors. So address the cause, obesity, diabetes, metabolic syndrome, treat them, so lifestyle. Modifications in lifestyle, especially diet and exercise, are still the pillars for correcting and preventing the progression of NAFLD into cirrhosis and hepatocellular carcinoma. This helps not only in reducing cardiometabolic risk, but also helps in progression to the later stages of liver disease. Different pharmacological approaches have been studied but are not effective or have limited efficacy. And in advanced stages of liver cell failure, which I have not touched upon in the talk, liver transplant can be effective alternative. I think with that I conclude, with this quote to say that an effective doctor is one who tries to prevent a particular entity from occurring rather than tries to treat it with a host of pharmacological agents, and NAFLD is a very good illustration of this concept or approach. Thank you.